All right, it's wonderful to be here. Thank you, Carlo, for the invite. This is going to be a fun day, I can tell, for sure. And we can start with the first slide. So again, I'm Paul Iaizzo, professor at the University of Minnesota. I've been there a long time, 34 years, and do a lot of different things, but I run the Visible Heart Lab, and I'm also the associate director for the Institute for Engineering Medicine. We're a land-grant institution. One of our roles is to train the next generation of medical device innovators. And you can see here on the left side, that's a reanimated human heart, something we uniquely do in our lab. We do a lot of outreach education. That's the free access website, the Atlas of Human Cardiac Anatomy. On the right, we're showing where the lab is. It's in the basement of the Mayo Building. The Mayo Building used to be the old hospital, and in the early 50s, it's the place where the first open heart surgeries were performed anywhere in the world with direct visualization of the congenital defect. And uniquely about the University of Minnesota, it's also one of the places where we had some of the first biomedical engineers. That means an engineer up in the operating room. And the first one was the founder of Medtronic, or Earl Bakken. And so it's a really unique place to work. So this is Earl Bakken, and I consider him the first biomedical engineer. Here he is in his brother-in-law's garage, Palma Hermsley. That equipment he's working on is probably University of Minnesota hospital equipment. That was his big contract. He was hired by the university to repair all the hospital equipment. When they started doing these open heart procedures, they had all these new pumps and heart-lung machine, and then eventually on the 100th case where they're using the heart-lung machine, they caused heart block, and they got a big grass stimulator and wires right through the chest wall into the patient. And Earl was an electrical engineer trained at the University of Minnesota. We're proud of that. He dropped out of a master's program to start Medtronic. Probably a good decision. And basically he's up there running the stimulator, not the surgeons. So he knew as an engineer that you only needed a millisecond pulse of 1 or 2 volts to pace the heart. And that was essential information to make the wearable pacemaker. So the preclinical trial, the one preclinical trial, was done in the same lab that where my lab is today. So it's really awesome to be in that same location. Here's a video from Earl describing this experience.
And that's when I looked up a circuit for a metronome in Popular Electronics magazine of that time. And one of the home projects in there was to build a little box that would put clicks on a loudspeaker the way a metronome sets clicks for timing music. And it's interesting that a metronome has the same rate range as a normal heart. You can adjust it from 50 up to 100 or 150 or so pulses per minute. So I plagiarized that circuit, in effect, modified it a little bit so it would be a 1 millisecond pulse, and put it in a little box with a 9-volt photo flash, a battery, and a little neon bulb to show you if it was pulsing, and brought it over at the university with Vince Scott, and we tried it one day on a dog in the animal lab. I hadn't necessarily built this to be used on humans, but the next day I came over to the university, and this was attached to a little child. And I asked Walt about it, and he said, well, he wasn't going to risk another power failure and losing a child to that.
So again, if you hear that story correctly, this preclinical trial lasted for 4 or 5 hours. The story is Earl visited the lab dozens of times. I actually met him that day, and he would sit in the lab, tell the stories that the plan was to keep the dog alive for several weeks. So he went home all excited because he just invented the first wearable pacemaker, actually one of the first battery-powered medical devices. And he gets to the U at 7 a.m. to go set up all the equipment, sneaks to the lab to see how the dog is doing. The dog's out of the table, Dr. Gott, one of the fellows who did his PhD also, is cleaning up. Asked what happens. He goes, well, after rounds, little eye comes to the lab, sees it's working, takes it off the dog dies, puts it up in the patient in the ICU. So they walk upstairs and they see it. Pretty amazing history. But this is how innovation happens. You know, the FDA started in 1938, but it didn't cover medical devices till 76. So they were totally legal to be able to do this as well. And a side note, one of the first functional micras, I saw it in your picture, we put in an animal in the same lab on the day Earl was visiting. So it's kind of fun history.
And that's...
So my lab is big. Right now it's myself. We have a large staff of scientists. Carr's our lab coordinator. We have someone that does just 3D printing. That's Rachel. David does all the computer stuff. Sammy helps with the animal setup. John's the curator of our heart library. So Carr is our lab coordinator. Weston does the tissue bath stuff. Gary's our full-time programmer. And currently there's 8 PhD students, 3 master students, and a couple postdocs. And we typically have over 15 undergrads working in the lab as well. But kind of the big thing of the lab is we're there to train the next generation of medical device innovators. And most of the people that train in my lab end up in the medical device industry, and they're all become experts in cardiac anatomy and physiology. So the lab does a lot of different things. I also saw your picture of the first Link implant. Dr. Lasky, who's here, and I've put them in bears. We probably implanted over 500 of these in free-ranging black bears in Minnesota, been studying hibernation physiology in bears, unique animals, trying to make all that back to translational. We do a lot of work on muscle force assessment, patients in the ICU, transplant research. Still the centerpiece of the whole lab remains the Visible Heart Project. And this started in '96. We were doing isolated guinea pig hearts. Dr. Lasky and my brother-in-law, Mark Jelly, walked the lab saying, could you do that with a large mammalian heart? We could pace it. Said, sure, why not? And within a few months, we had it running. Basically, you're just doing a standard cardioplegic procedure, removing the heart with the great vessels, cannulating it. And then we have a multimodal function, so you can have a Langendorf mode, but you can quickly switch pushing buttons now, servo motors, and go right into 4-chamber working mode. This is Dr. Lasky's here. This is a video that he brought of the Medtronic 5076 lead that we did in '99, showing that we could, there's a camera in the back. You can see the lead there, basically showing that it's an active fixation lead that you could quickly move it and move it around in different locations of the heart. So again, the beauty of the Visible Heart is that you can study the device tissue interface. So if someone asks me, can you put that lead on the moderator band, which you see there in the middle, so the anterior papillary is on the right, the moderator band going to the septal wall, I could get it on there. And that's the beauty, is that you can see the precise anatomy and you can study the precise device tissue interface. You know, this is nothing new. Oskar Langendorf, who is a German physiologist from Rostock, described the Langendorf mode of isolated hearts back in the late 1800s. And, you know, basically they took isolated canine hearts, they used blood, whole blood, and they perfused it. They couldn't see inside. So the difference is we have cameras and we see inside. So it's done with a clear perfusate. It's a Langendorf mode we can start in, but we can, you know, use the Krebs Henslate buffer and go into full functional working mode. Because there's no red blood cells, you don't have the oxygen carrying capacity of blood, so 40-fold less, it'll die of global ischemia. But it gives you a window of 5 to 6 hours to study this, and we're like Hollywood. So we basically have all the different imaging equipment. So we can use multimodal imaging. So we can use endoscopes. You can do a C-arm. We've done IVUS. We have small fiber scopes, 2.4 millimeters. We can go into the cardiac veins and the arteries, do a lot of stenting work. We have OCT, we have 40 echo, and high-speed cameras. So again, we'll line up the shot. It can be in right side working mode, then we go to full working mode, and then we can see all that functional anatomy. So it's just really a fun operation to be able to do this creative multimodal imaging on a given device tissue interface. This is how I remove the hearts. I learned this from Indiana Jones. So, and I do work out my hands. I have really strong hands, so don't get me angry. I know this technique. It's very quick and effective. You get the heart out quick, and you have to do it with the great vessels. So you can cannulate the great vessels. No, I don't use this technique, but I do wear the headdress. Every time I do this, it gets heavy by the end of the day. And this is an old joke, and I thought, I can't keep using this joke. But it turns out there's Indiana Jones 5. He's been doing this his whole career, so I'll use the joke my whole career. So it's kind of fun to think of this. But again, really we do on a routine basis, we're doing swine hearts, we've done other animal hearts, and you can study the device tissue interface, different devices. So this was a canine heart that was reanimated with chronically implanted leads, and we could take the spectronetics laser and do lead extraction studies. So again, this can be, cute studies with swine hearts. We could get different heart models for it of heart failure, but also then, we can have the privilege of using human hearts. This is rare. That's a couple times per year. Typically, we've been doing this since 2000, so we've reanimated 98 human hearts. That means there's a heart not deemed viable for transplant. We can get it to the lab within 5 to 6 hours. Typically, you need an ejection fraction over 50. If it's longer than 8 hours, they just don't work because you're using a clear perfusate without red blood cells. They still respond to catecholamines, so you can still try to get that. So first 2 hours, it's dedicated just to get all the functional images to go on the website. So we get these hearts gifted to us, so we want to gift all that functional anatomy back to everybody. Then after that, the grad students that are doing work on isolated swine hearts can do it on a human heart, making the work translational. And then after that, with our Medtronic partner, we've been partnering now for over 27 years, we'll bring in various devices with the understanding that these, because they're in human hearts, these have to be made public in a reasonable period of time. So we've done all kinds of different devices in these reanimated human hearts. Amazing privilege to be able to do this. If you don't have my business card, you can see it through the right atrial appendage of a human heart right now. So this is kind of mind-blowing how thin-walled this can really be between the pectinate muscles. You can actually read the University of Minnesota there. That's where we're from. And this is not atypical. This is typical. So every time we get a human heart in there, we do the business card thing on there, trying to read it through there, read the University of Minnesota. One of the things I'll show you at the end, we have a QR code now for all the free apps. And the last human heart we had on there, and you could actually read the QR code through the right atrial appendage. But again, it shows you how thin this can be. It's functional anatomy. And then again, just like everybody in this room has a unique fingerprint and thumbprint, everybody has a unique heart. So you guys that are doing clinical procedures, you're doing personalized medicine every time you step into the cath lab. And this is important to think about, that this isn't going away either. This is where you can't use AI, it's personalized medicine. If you haven't seen atrial fibrillation from the inside of a functional human heart, here it is. You can see this chaotic contractions, how it can be randomized, the patterns can change. We can have hearts that'll come in like this. We can also induce it. You can do acetylcholine injections. You can do burst pacing. You can actually induce this AF and then visualize this down with the cameras. And this would be more of the septal wall. You can see it kind of quivering there. And then we can also do ventricular fibrillation. But since we're focusing on the atria today, here's your atrial fibrillation. And then we can do ablations. This is RF ablation. You say you want to isolate the triangle of Koch. Basically, I can take a catheter and I can burn it and point by point, and I'll have no gaps because I can see it. I can see the lesions form. And that's kind of unique that in the lab for RF, you can see it. For cryo and pulse field, you don't always see a color change like this of the tissue or desiccation, but with RF, it's quite visible. And then if you said, now I want you to put a pacing lead in this isolated tissue, here I'm putting a 3830 lead right over the triangle, probably close to the AV node, and then I can pace the ventricles, so I can do basically physiologic pacing of the conduction system and isolated my whole atria. Again, you can kind of see the whole lead there in the device tissue interface. You can actually see what happens when you do too much energy. These are typically isolated swine hearts or human hearts. So we can go ahead and change this. This is a research tool then. You can also use your high-speed cameras, and you can see the desiccation of the tissue and the gases being released, and you can actually hear the pop audibly as well in the lab. And we did a bunch of different studies on the thresholds for this and looking at all now the different tools, catheter sizes, angles, shapes, different anatomies, regional effects of doing steam pops. And then comparative anatomy, like I said, we're lining up the cameras. Here's the aortic valve from above, from below, and then we can put echo probes on there. We can put ICE probes within the heart. We can have fluoroscopy simultaneously. So we'll do all this multiple imaging. This is a video that comes right off the Atlas website. And every video on the website is freely downloadable. And if you wanted, you could put them in your own PowerPoint presentations. There's probably over 5,000 videos and stills on there, and we keep adding stuff on a routine basis. So it's kind of a labor of love by everybody in the lab. So everybody's got to contribute, but that's how they become an expert in cardiac anatomy. So a human heart comes in, and we can reanimate it. So we're going to look at all the functional anatomy. We'll do the echoes as well. We'll have fluoro on there, so you can see multimodal imaging here. We'll also do PV loops. We use conductance catheters now, and we'll have continuous functional data, right side, left side. We can also do electrical mapping in there. We've done MAP4 catheters to do, monophasic action potential work. And then afterwards, the heart is isolated. It's perfusion fixed under a pressure load. And then once we have that, we can then basically look at the conduction system. Whoop, that's interesting. Go back here, sorry. Oh, jumped funny there. Sorry. And then we can also use diffuser tensor MRI to look at fiber orientation. So this has really kind of been the ongoing focus of the lab going forward now. And sorry, just jumping ahead. And then we have a collaboration with Kalina Dobozinski's group in Manchester. And these are human hearts that we've sent them. It's taken them years to get this, but they can start to look at the anatomy of the conduction system in high detail. And you can look at the right and left bundle branches. You can look at the SA node. You can look at the preferred pathways in the atria. These hearts, they'll stain the hearts. They'll perfuse them in staining for months. Then they'll CT scan them. And then it's taken them years to do the reconstruction. Our goal is to do this quicker, but yet to get this kind of detail now. So they've set up a perfusion system. So one of the days we were having a discussion, Neil Doon, one of the PhD students, were like, why don't we just perfuse the coronaries? with the iodine. So we did that, and within hours and days, you can start to see the full staining that you need then to be able to do the micro CT. Turns out we have a micro CT scanner in our lab. So if we want, we could do this every hour. So he's doing temporal studies of staining and then looking at all the anatomy. And then you're looking at the low glycogen. You can start to identify the fibrous conduction system and pathways within a given heart. So these are some of the ones that we've generated now from human hearts. You can start to begin to look at the SA node and some of these pathways. You can look at the AV node. We're very interested in the left bundle branch now because we're interested in left bundle branch pacing, and this is part of Neil's project. He's also looking at Bachman bundle pacing, and then more physiologic pacing, atrioventricular, with this alternate site pacing. What's interesting, Dr. Lasky's sitting here. He did his PhD in my lab some 20 years ago. He did conduction system pacing 20 years ago. The technology and the tools weren't there and available, and the technology had to catch up to the research. And that's important for all the PhD students here in the lab. Sometimes your research is going to take years to catch up clinically, but still it's important. Also, the goal will be able to do this in swine hearts. So this just shows then some characterizations of this in the swine and human. There is variability, but we really want to characterize the preclinical models so we know how good they are as preclinical models relative to human anatomy. So we're looking at this. We're also looking at pathologic changes with disease, sick sinus syndrome, heart failure. We actually have a library of hearts that we know have some known previous electrical or heart disease problems, and we can then go back and try to characterize these anatomically because they're all there in our heart library. So you can kind of see that these are all 3D, and you can rotate, create these models. You can also put this in virtual reality, which Neil is doing, so you can do fly-throughs through all this anatomy. Oops, sorry for the noise, but this just shows, where he's trying to do Bachman's bundle pacing. You can then see the Bachman's bundle anatomically in this, and you can just see your right atrium, your left atrium, and you can see this change in the staining then. And these are these preferred pathways that you're trying to excite when you're doing Bachman bundle pacing. All right, want to go forward? Yeah, just hit the next slide, please, or... Oh, okay. And then we're comparing this with histology. So some of the hearts we've selected then to more or less dissect afterwards. So we have our micro CT, we have the staining, we're confident that we can see it in the micro CT, these preferred pathways, and then we'll do histological staining to verify this more in the classical way of looking at these conduction pathways. The other thing we hope to do is diffuser tensor MRI of all these specimens. And this is non-destructive again. So is the iodine staining. It turns out that you can rinse all that iodine back out of the heart after several days and still preserve that specimen. So then we'll bring in these specimens to our MRI scanners using diffuser tensor MRI, trying to look at the fiber orientations. We have this pretty well. We can do the ventricular fiber orientations. The next goal was to bring this and try to do this atrial as well. We actually have a 94.4 Tesla magnet at the University of Minnesota that we've collaborated with that we hope to bring our specimens into these higher magnetic fields to better discriminate the diffuser tensor orientations. Again, like I said, we have a heart library. We have over 800 human hearts in there. About 650 are perfusion fixed. That means that these are still viable and intact, that you can do these different studies on. So just think, I mean, if we had a small army of students and scientists and clinicians, we could maybe do all the conduction systems on all these hearts, all the diffuser tensor MRI, the fiber orientations. We're down to, with our micro CT, down to a 90 micron resolution of all this anatomy in these hearts. If you focus the energy on the device, you can get down to 15 micron resolution of device tissue interface. So again, it's this huge opportunity. And we call it a library. That means it's open to all students, all academicians, and everybody from every company. So we've had people in the last couple of weeks from, Edwards Life Sciences, Abbott, and Medtronic, all utilizing these libraries. So they can rinse the specimens, study them, they can take videos, they can take measurements. We have scans. We'll provide a lot of the scans for them. Again, this is all a resource. We're trying to really collaborate with everybody. We're happy to share these with the group here or anybody in the room as well. We also have done a lot of the combined epicardial endocardial mapping. We have this collaboration with Medtronic, and they've been able to share with us their Cardio Insight system, and periodically they'll bring in their Affera systems, and then we can use these systems in a preclinical setting. So basically, we have to figure out how to do that. We'd like to do that in an isolated heart. So we've actually made our own vest, so to speak, of 252 electrodes inside a tank. Then we'll take the tank, we'll take the heart, we'll bring it to our CT scanner so we get all the orientations. And then we can bring the Affera system in there simultaneously. So we've done endoepicardial mapping simultaneously in the same specimens. We've done this in a number of swine hearts already. And this is something where Neil and James Villar, who's looking at ablation technologies, can then look at these epi-endo maps simultaneously while they're applying the various technologies in these isolated preclinical studies. So you can get the maps. So these would be maps then. So you can look at alternate site pacing again. This is what Neil wants to do. And we can look at this conduction pacing, but we can also do, RV apical pacing, or you could say, I want you to put this on a papillary muscle. I can put it on because I can see the papillary muscle. So this is the unique thing that the visible heart brings, is the precise device tissue interface. And then here it's just showing that we've done some of the, Affera catheters and the differences. We can also see precisely where they go in the anatomy, how well they interface with the anatomy, and this can also be in human hearts as well. So we've actually want to really, moving forward, do all this epi-endocardial mapping, do all the technology research, pacing or ablation, and then afterwards take those hearts and then really study the specialized conduction system in that given specimen. Diffuser tensor MRI, put all that together with computational models down to a 90 micron resolution. We also have done the cardiac, the Insights system with a human heart, and this just kind of gives you a view of that. So we have a human heart functional within the tank here with the 252 electrodes, kept obtaining real-time activation, repolarization maps, and then we could do the alternate site pacing or different ablations in a human heart as well. So again, when you're doing that, what we really want to do is we want to look at all the functional anatomy. We want to be able to look at all the conduction system anatomy. We want to compare that then with all the precise anatomic features of that given specimen. And so this is kind of where we're moving forward. This is part of Neil's PhD thesis work. So just to finish up, a couple more slides. We do a lot of outreach education. So For the Institute for Engineering and Medicine, I'm the Associate Director for Professional Education and Outreach. So we've created a lot of these free mobile apps. There's a QR code there. These are all downloadable. You can go online. If you can't get it off your phone, I've got a bunch of cards. I'll lay them out back by the water. You can grab the QR code. And again, this is our outreach mission. So we have TE simulators. We have stenting simulators. We're developing congenital heart one. There's one just on the heart itself. Again, this is a big outreach mission of the lab. So really the Visible Heart Lab focused on translational research of reanimated large mammalian hearts, including human. Human atrial anatomy is super complex and highly variable. We also want to look at the effects of disease and the conduction system, the fiber orientation, and the detailed anatomy. And the real-time activation maps with the hemodynamic assessments allow us to look at critical assessments of therapeutic responses and combining that with our post-anatomic assessments of these same specimens. So we can look at the conduction system, we can look at the fiber orientation, and we still obtain these hearts. They're immortalized in the lab, they're in a formalin. We've had some of these specimens now for over 25 years. So again, thank you. There's a lot of people that make this possible in my lab, collaboration with Medtronic. We still all the past and present students. I know Carl is doing that here with his past people. This is a critical ecosystem that you can continue to work with because they're the ones bringing back ideas all the time. Collaboration is key. And again, I was able to see that they have visible heart here too. In their hybrid OR, and it was very impressive for that. So thank you. And yep.
Thank you very much, Paul. It's a very nice presentation. Is any comment or question from audience? If not, may I have some questions? So the visual heart is very impressive for me, and also it's very important combination anatomy on the and also electrophysiology in the. But you mentioned about maybe normal heart, but sometimes patients has a very specific anatomy, such as congenital heart disease. Is it possible you also show such kinds of information in such kinds of
yeah, no, that's a great question. So we're working on that. We have a number of congenital specimens in the lab. I think the youngest heart we reanimated was 6-year-old heart. And we're trying to obtain all the specimens from the recipient who's getting a transplant. We've been able to scan and start to look at all this anatomy as well. But this is a big mission. We do a lot of pre-procedural planning in our group. So we'll get angio CTs or MRIs. We'll make computational models, and we'll share that with the clinicians. And we'll actually do 3D prints, high-resolution 3D prints. And so they can use that for pre-surgical or pre-procedural planning. And that's just something we've done in my lab for the last probably 10 years. So we actually have a huge array of different congenital defects. And then these can be used for study and education. Like I said, there's a mobile app on congenital heart as well.
Thank you very much.